Sir, thank you for the opportunity and good evening, everybody. Welcome to today's webinar on COVID-19 crisis, present and future, Arkansas's leadership experience. I would like to thank the President API, Dr. Suresh Reddy Garu, and the Chairperson of the Board of Trustees, Dr. Seema Arora Garu, and other distinguished leaders and members for the opportunity. We are really privileged to be part of this vibrant organization nationally and also in the state of Arkansas, who are very much in the front lines fighting the COVID-19, which is arguably the most dangerous public health emergency so far. I'm honored to be moderating today's session. I'm Chandra Lingasedi, the Chief Administrative Officer at Baptist Health Physician Partners in Arkansas. I would like to invite our state chapter president, Naveen Kumar Jain, to open the webinar today and say a few words. Naveen Kumar Jain.
Yeah. Can you hear me, Chandra?
Yes, Naveen.
Yeah. Thank you, Dr. Suresh and team. I really appreciate National RP for taking up the initiative and educating individual specialties in managing COVID in terms of standards of practice and bringing in personal experiences of the specialists who have treated COVID patients. The panel today, as you all know, is comprised of physicians from Arkansas. RP Arkansas has been in the forefront of donations. We have donated over $250,000 in the last 7 years. During the COVID pandemic, we have donated masks for healthcare providers in the hospitals, clinics, and nursing homes. Till date, we have donated over $15,000 worth of N95 masks, both in the US and India. This could only be possible due to generous donations from RP Arkansas family. We are also very glad to hear that Dr. Anjana has come out of danger and is recovering well. We wish the same to other members who are fighting COVID-19. Our prayers are with those patients and healthcare workers who have lost their lives. So we would like to appreciate all the healthcare workers in Arkansas, the rest of the US, and the entire globe who are fighting this pandemic. So without much ado, I would like to thank the panel members and welcome our moderator for today, Dr. Chandra Lingashetty. Go ahead, Chandra.
Thank you, Naveen. By the way, I'm also the Vice President of API Arkansas chapter and a member of the National API, and I'm really honored to be part of this group. So as you know, COVID-19 hit several nations at different times. Within the US itself, it has hit different states at different times. In Arkansas, it was March when we recorded our first case, and our state leadership and public health departments instrumental behind very prompt, effective, and comprehensive response to the pandemic. We were one of the few states that did not officially declare stay at home or stay in shelter orders, but most of our public and private businesses responded very responsibly and helped the authorities to control the transmission of infection very quickly. However, reopening is expected to change that a little bit, maybe. And now I would like to welcome Dr. Naveen Patil to talk about his experience being at the helm and share his thoughts on, is there a second wave? It looks like it is, there is a second wave. And how is he preparing for that? And as you all know, Dr. Naveen Patil is known to pretty much everybody in API, outside API, everywhere in Arkansas, and also nationwide as well. He's a COVID-19 task force member for the state in the capacity of as the Director of Infectious Diseases Division, Arkansas Department of Health. Dr. Naveen Patil, over to you, sir.
If Patil is muted, he has to unmute himself.
Hello?
Yes.
You can hear. Yeah,
Naveen
Naveen, you can talk.
You can hear Naveen Patil, go ahead.
So, Chandra, you may have to unmute him.
Hello.
Yeah, we
Navin
can hear
Patil.
you, Patil.
Yes.
Are we starting?
Yes,
Yeah,
yes. Navin, yes. Go ahead. Navin Patil, yes, go ahead.
Good evening, guys, and thank you for giving us the opportunity to present with RP USA. I have several of my colleagues with whom I have worked very closely. My colleague at the Department of Health, Dr. Kothari, and Dr. Tina Ipe, I guess she's also in there. With whom we worked on setting up our blood transfusion process pretty quickly here in Arkansas. I was basically asked to give an update on how the leadership experience has been in Arkansas and about preparing for a second wave. Technically, we are still in the first wave, and I do not think that we've ended our first wave as of now, but I'm sure there'll be a bigger surge in the coming months. So I would like to give a brief background on how we started our process here in Arkansas at the Department of Health. We had a very supportive leadership at the Arkansas Department of Health, and also Garner, who was very proactive. The moment we had our first 2 or 3 cases, we shut down all our schools. And even before we had our cases, we shut down all our long-term care facilities, nursing homes, assisted living facilities, other congregate settings like human development centers, substance and alcohol abuse centers, all those things which had a large population of people at high risk were all shut down. Similarly, for the state jails and state prisons, they were all shut down, no visitations, and no movement of inmates from one jail and one prison to other. So all these proactive steps were taken even before any cases occurred. So this helped us prevent a New York style situation where New York was kind of a little bit late to react for this. So have seen Arkansas actually did really well in the first 2 months, where we had lockdowns and not technically a lockdown, but basically closing down of several things, including restaurants, places of worship, and those kind of things, where people were asked to do things from home. Many offices had were asked to work from home, and so on and so forth. Arkansas, I think, was among the 4 states performing well for the last 2 months. And once actually we had almost about 5-6 weeks ago when we started reopening, that's when we started noticing issues. Basically, people took this lightly, I should say, and social distancing and masking were not practiced well, and now we are seeing a surge in cases. I would like to highlight a few things that Arkansas did really well, for which we have been recognized both nationally, and CDC wants to study on how we were able to do this. One aspect was for nursing homes, long-term care facilities, where in any of these facilities, whenever we had either a resident of that facility or a staff member who tested positive, we aggressively tested the entire facility, all staff and all residents, and identified positives. Our goal was to, within 24 hours test, within 48 hours result, and by 72 hours provide infection control guidance to all these facilities. In this way, we have prevented a lot of morbidity and mortality in our nursing homes. If you see, Arkansas's nursing home deaths are not high, although every death is a sad event. Our number of deaths is less than 100. It's about 95, 96. Our total deaths are about 250, I think. So although we constitute about 40% of the total deaths in nursing homes, the number wise, it's not significant considering that we have almost 30,000 plus 35,000 people living in these type of congregate settings. So we have been, our approach of aggressive testing has been well applauded nationally and also by CDC, which is studying us. Secondly, starting the first week of this month, we are proactively testing all the long-term care facilities in the state. As of today, I think we have completed testing in over 250 plus facilities. About 30,000 people have been tested, both residents and staff in these long-term care facilities. And we are very proud to say that the number of positivity rate in this is 1% or less. So we have done really well in providing guidance and assistance to these long-term care facilities. Since the outbreak began, my team at the Department of Health has visited almost 100 nursing homes and assisted living facilities, jails and prisons, and provided on-site infection control guidance. And this has been one of the highlights of our success. Arkansas has prepared its nursing homes, hospitals, and many other facilities well before COVID as part of our infection control assessments dating back to the Ebola outbreak. So we take really pride in that, and I think we are one of the top healthcare-acquired infection control programs in the whole country, helping out several other states and national organizations like CDC during this pandemic. I think in our current upcoming thing, what we plan to do is aggressively educate all facilities on infection control. We want to reach out to all congregate setting facilities by the end of August, before we anticipate a peak in the number of cases again in September, October, so that they are provided adequate guidance and any assistance they would need in handling the higher number of cases that we anticipate towards the fall and later part of the year. I would like to stop now because we have a full agenda and we are already running behind schedule. I would like to entertain any questions later on if needed.
Naveen Patil, thank you so much for your insights and guidance. As we all know, an effective response to pandemic needs estimation of the disease burden. And so testing is an integral part of estimation of that. I would like to welcome Dr. Atul Kothari to share his thoughts on current practice and capacity expansion. Atul Kothari is an expert at the Outbreak Response Section, Arkansas Department of Health, and adjunct professor of Department of Medicine and Biomedical Informatics at the University of Arkansas for Medical Sciences. I would like to invite him to share his thoughts.
Thank you, Chandra. Thanks for inviting me to talk at this forum, and thanks to Naveen. He's been very humble about the role which he's played in limiting the outbreak of disease, at least during the first wave in Arkansas. So the way I think about COVID-19 is, if you know that there was a pandemic arriving in 4 months, how would you prepare? And the first thing that you want to know about a new disease is having a good test for it and having enough testing available to detect the disease. As you all know, that the benchmark test is the nucleic acid amplification tests. And for those of you who've been following these nucleic acid amplification tests or PCR tests, there's a huge bunch of them which have been approved by the FDA. And these are different vendor-specific technologies which were created to avoid patent royalties for a particular brand of PCR. But the predominant test which is used is real-time polymerase chain reactions, or qPCRs. And for those of you who are a little bit geeky like me and want to know about values, often you get a test result. You're used to getting test results with copy numbers, whereas in COVID-19, most of the tests that you see either give you detected or not detected. We actually can calculate these cycle threshold values which correlate with the amount of RNA present in a particular sample. And next slide. So the FDA, under its emergency use authorization, has approved a large number of these nucleic acid amplification tests. These are broadly divided into two categories. One is these high complexity molecular based lab developed tests, of which as of last Friday, 37 had been authorized. So most of these are in high complexity labs, say like Stanford or Mass General. Here in Arkansas, UAMS has a high complexity lab developed test. And then there are about 80 authorized in vitro diagnostic tests. These are also PCR tests. And these can be divided into two broad categories: high throughput tests and low throughput tests. So high throughput tests are done by large labs like Quest, LabCorp. They are amenable for large hospital systems like here in Arkansas, like the Baptist Hospital System. Low throughput tests are more useful to individual practices. To give you an example of high throughput capacity tests, this slide shows you what are the different companies which have high throughput tests. You can see Cepheid, BD, Abbott, Hologic, Roche, etc. And high throughput tests can do anywhere from a few hundred to several thousand tests per day. On the right hand side, Chandra, if you can play the video, um, this is a video of the Perkins Elmer platform here at at the Arkansas Department of Health, which we've bought, and this can do 1,000 tests in a day. We are actually getting a second platform as we speak, so we will be up to about 2,000 tests per day at the ADH. Next slide. And then there's only one antigen test, the Quidel Sophia 2, that has been approved so far. I won't say anything more about the antigen tests. So some frequently asked questions which I've gotten from practitioners, which I'll try to address in this short talk. One is, when should sample be collected? Which is the best sample? Can saliva be used? And how can we interpret results in asymptomatic patients? So let me go over those one by one. So this slide addresses the first and second questions: which is a good sample and when should samples be collected? So we can do nasopharyngeal swabs, sputum swabs, and stool samples. Stool samples cannot be used here in the US because even though virus can be shed in stool, none of the approved FDA approved tests actually are validated for stool. So it can only be done in a research setting. As far as nasopharyngeal swabs are concerned, that's the number one sample which we get. And those are positive in the first 7 to 10 days of the disease. And then cycle threshold values can sometimes go down below the level of threshold, below the level of detection, I'm sorry. Sputum samples can remain positive for longer periods of time, for up to 2 to 3 weeks. I'd like to clarify right over here that positive PCR does not always equate to cultivable virus. We've actually seen these studies come out of the CDC and Germany, where they've tried to cultivate virus from patients after 10 days. And even though their PCR has been positive, we've not been able to culture the virus out, which is why all local health departments have guidelines about isolating patients for 10 days. The third question, which I sometimes get asked about, is about saliva. Can that be used for testing? So there's some studies out. This is one which I like, which shows that saliva is actually more sensitive for SARS-CoV-2 detection than nasopharyngeal swabs. In fact, now the FDA has approved its first test I think in May 8th, where saliva is approved as a sample. But most of the tests which are available do not have saliva as an approved sample. So you'd have to get this specific test if you wanted to use saliva as a sample for detection. The fourth question is, how do you interpret results in asymptomatic people? So we don't understand viral load levels or kinetics. Anecdotally, when we've started to screen a lot more people, a lot more contacts, what we've seen is that the PCR becomes negative pretty quickly after the first positive. From a public health perspective, our guidance has remained the same. Even if a person is asymptomatic, you should be isolated for 10 days, or you should have 2 negative tests 24 hours apart to clear isolation. In these asymptomatic folks, we should probably be using very sensitive tests because you expect that their viral load to be a little lower than patients who are symptomatic. My last slide is on serology, which is like the wild, wild west. So there's 20 tests which have been authorized by the FDA. There were 2 rapid tests. Now, over the weekend, the FDA actually revoked the emergency use authorization for one of those rapid tests, the ChemBio test, because their performance did not come up to expected with time. So now there are 19 authorized tests. The other 18 are ELISA-based tests. Neutralization tests have not really been authorized by the FDA. They are in research use only, and Dr. Wright may be talking more about it. There's several issues with serology testing. You can have a highly sensitive and a highly specific assay, but they have different issues with them. A highly sensitive assay may not tell you about immunity because it may be picking up very low levels of antibody. A highly specific assay may have a higher rate of false positives in areas with low prevalence of disease. So your true positives may be outnumbered by the false positives. So essentially, nobody really knows how to use serology. How do you use them? The best time to use them is really for research studies. It's really, you should not be using serology for diagnosis at all. So you can do cross-sectional studies, you can do cohort studies, you can do targeted population studies, and folks have talked about getting tested for your personal knowledge as well. However, I would really caution anybody against trying to get tested for their personal knowledge because we don't understand enough about serology and we really don't know whether it means that you're immune from the disease or not. So that's it. That's all that I have, I think. Yeah, current tests are not sufficiently accurate. Thank you so much.
Thank you, Atul. Our next speaker is Tina IP. As you know, medical management for COVID-19 is changing every day, and it has been going through dynamic developments as we speak. We know that the options are not too many out there. What we surely know is convalescent plasma might work in some other patients, especially in selective cases. We will now welcome Tina Ipe to share her thoughts and insights on convalescent plasma therapy. I would like to stop sharing my screen so she will share her screen and talk to us. Tina, over to you.
Thank you. Sorry, there we go. Can everyone see my screen? I'm going to make myself a little low. Okay. So, I want to thank API for giving me this opportunity to speak with everyone. I'm very excited and, of course, a little bit nervous about, talking. But I want to, so the objectives of this is really to get an understanding of how COVID-19 plasma works in our population. So to preface this presentation, in Arkansas, we've actually been dealing with this pandemic for about 16 weeks. And when it first reached our state, no one really knew what to expect, how badly our state would be affected, and how stretched we might become with our resources, and the lack of treatment options for patients that were decompensating rapidly. So what this presentation, I hope, does is that it showcases our responses as a state and a hospital in providing convalescent plasma for Arkansans with severe and life-threatening COVID-19 infection. What we will do is we will briefly talk about CCP, the Arkansas Initiative, and the preliminary results from this initiative. So what is convalescent plasma? So convalescent plasma is really collected from an individual that has recovered from COVID-19 who goes on to donate plasma. The plasma, as you can see, gets tested. And what I mean by tested, it means that the person answers very specific questions about their travel history, medications that they're taking, and in addition, it's tested for infectious diseases. Once it's tested, the plasma goes on, gets stored, it gets stored, and for us, gets sent to a distribution facility. When there is a request for convalescent plasma by the hospital, it is then transported to that hospital, and then the patient is treated with the plasma, and then the therapy is complete. The person who has now recovered can actually become the donor. So convalescent plasma is really fresh frozen plasma. For many of you, you have an understanding that fresh frozen plasma is usually collected using a whole blood collection, but convalescent plasma is actually collected using a donor apheresis machine. And what occurs is that the person gets on the machine and they collect about 400 to 600 mLs of what we call FFP. But again, because this is collected from someone that has recovered from COVID-19, we call it CCP. Now, many of you know that the traditional indication for management of individuals that are bleeding or have low clotting factors is actually FFP. But CCP is very unique in that it contains proteins in the form of antibodies. And these antibodies are then passively transferred through the process of transfusion to a person who is trying to fight the COVID-19 infection. So Arkansas, briefly, is actually a state of 3 million people. And the first case of COVID-19 in Arkansas occurred on March 11, 2020. What occurred is that through the leadership of individuals like Dr. Patil and Dr. Katari and others, early contact tracing had enabled the Arkansas Department of Health to determine individuals who had come into contact with patient 0, to test those individuals and then to quarantine them. And what the Arkansas Department of Health has really done is that it's created and maintained a registry of all tested individuals in the state. And what you can see from this slide is that to date, there's about 250,000 individuals that have been tested. Of those, there's a 6% of individuals that have tested positive. What I really want you to focus on is actually the patients in the hospital. We have currently all over Arkansas about 231 patients that are in the hospital, and 57 are those that are on the ventilators and potentially could be beneficiaries of convalescent plasma. So what is the Arkansas Initiative? So the Arkansas Initiative for Convalescent Plasma was really developed as a means to ensure that every Arkansan had access to convalescent plasma. When I was first approached by the ADH to collect convalescent plasma mid-March, And what I'm showing you is a phased approach that was used to provide 2 units of convalescent plasma for every Arkansans. So what we did was we, first created a guidance document and did an outreach to all the hospitals in the area. And this was actually to educate them about the different mechanisms that they could actually obtain convalescent plasma. And I will go into that briefly. But then at the same time that was occurring, we also did donor recruitment of those individuals that had recovered in the community and were willing to actually donate convalescent plasma. And then subsequently, you can see that within a very short period of time, there was a request for a patient to be treated with convalescent plasma. And given all of our conversations with many hospitals around um, Arkansas, we decided, actually the University of Arkansas for Medical Sciences decided on creating an expanded access treatment program for the state. So ADH, the way that we were able to be so successful is that there was a very well-defined partnership within the University of Arkansas for Medical Sciences, the Department of Health, as well as ABI. And for many of you who don't know what ABI is, it's the Arkansas Blood Institute. And what they do for the state is they actually collect convalescent plasma, and they are one of our largest blood collectors in the state. But we're also served by other blood collectors, such as the Community Blood Center of the Ozarks, LifeShare, as well as Jonesboro, which is served by the American Red Cross. Now, I had previously shown on the first slide that our first donors was collected, actually on April the 8th. And the donors actually had to meet very specific requirements that were set by the FDA. And the requirements is that they needed to have a diagnosis of COVID-19. This had to be documented by a laboratory test, which is a PCR test using the nasopharyngeal swab. The donor had to have complete resolution of symptoms at least 14 days prior to the donation. We now collect from individuals that have complete resolution of symptoms at 28 days. They can be male or female donors. However, if they are female donors that have previously been pregnant or had an abortion or any of those things, they would have to test negative for the HLA antibodies. And this is because HLA antibodies mediate a mechanism called transfusion associated lung injury. And so because of that, we do have to test women that have been pregnant or are multiparous for HLA antibodies. And similarly, because there was a time when we were collecting, when we were collecting at 14 days, we had to have a negative result for COVID-19, either from nasopharyngeal swab or some other molecular diagnostic test. Now, the other thing that I want to highlight is that we had really wonderful hospital partnerships that have been listed for you here. Now, for a patient to actually receive convalescent plasma, they too have to have laboratory confirmed evidence of COVID-19 infection. They have to have severe or life-threatening COVID-19. The FDA has defined severe disease as the following, and you can see number 1 through 5. I'm not going to read that for you. And they also have defined life-threatening disease as being one that has respiratory failure, septic shock, or multi-organ dysfunction. Now, in addition to all of this, the person or their power of attorney, medical attorney, or their what we call their representative has to be able to provide informed consent for the receipt of convalescent plasma. Now, convalescent plasma is investigational by the FDA and is undergoing very thorough trials, not only through the expanded access, but also through various clinical trials that are occurring through the country. So our first patient was actually treated with convalescent plasma on April 8th. And since then, we actually provide 2 units of convalescent plasma for every patient. The one thing that we had decided to do in our ability to provide convalescent plasma for everyone is that the Arkansas Blood Institute titers these individuals, and they titer these units for not whether the person has antibodies to COVID-19, but actually for what we call isohemagglutinins, and they are basically the antibodies that are present in blood. For example, a person that is a blood group O is going to have anti-A and anti-B present in their blood. So that's what is being titered. And the reason for these titering is such that it would allow for us to cross some blood incompatibilities. And then for the most part, we've also allowed for additional units to be provided if needed. Now, we are collecting data from individuals, and we have collected about data from about 45 patients. And this is using the FDA EIND mechanism. And the FDA EIND mechanism is a single access use, which means that every patient has one number associated with them, and the convalescent plasma is distributed to that number. And so for the 45 patients, we have distributed about 89 CCP units, and the reason why it's 89 is because one patient, a patient died post receiving one unit, and it was not secondary to it was not secondary to CCP, but rather it was their disease. So the exploratory objectives that we are actually gathering and taking a look at is the ventilator days and the ICU admissions, the hospital mortality, the hospital length of stay, the type of respiratory support that occurred, and then how they improved post the receipt of convalescent plasma, the duration of the respiratory support, and in particular, the adverse events related to convalescent plasma. And then once we are able to actually get neutralizing antibodies, we are not only going to do the SARS-CoV-2 antibody titers on the donor specimens, but also to determine if these antibody titers equate to immunity in patients. So what our study has shown is that the average age of patient was 56.54 years, and the range of patients in our study went from about 47 years old to 85 years old. As you can see, there was a male predominance to the disease of 1.6 to 1. This is very similar to the dashboard that is present at the Arkansas Department of Health. There is a male predominance. What is different is that our study showed that those individuals that tended to be hospitalized as well as who tended to be intubated was disproportionately minorities. And you can see that Pacific Islanders, African Americans, Hispanic, Caucasians, you can see the effect. And then what you can see also is that we find that 2 units of convalescent plasma conferred a 70% survival rate in the patients that received it. It goes without saying that there was an increased survival benefit if the treatment was given earlier in the disease. We are still, we are on the cusp of publishing this data, and so because right now there's data pending on about 27% of the patients who are still hospitalized. And what I want to highlight is that there's really been no adverse events reported secondary to the CCP transfusion. Now, what I would like to say is that our data is very similar to other published studies. However, our study is very different in the provision of 2 units of convalescent plasma. Similar to the Mayo study, which treated about 5,000 patients, they, showed that there was an incidence of less than 1% of adverse events related to CCP, and this tended to be mild. Again, the mortality was really secondary to the disease rather than to the receipt of convalescent plasma. So, I hope that in time, we would be able to, you will see our data being published, and that, you can see the benefit that convalescent plasma has, especially in states where there isn't as many access to different type of therapies, such as in Arkansas. So with that, I'd like to acknowledge all of the individuals that have helped us become Arkansas strong. Thank you so much. Hello?
Hey, that was good. I think somebody's lost audio.
Yeah, I'm here. Tina, thank you so much for that's such an informative insights into convalescent plasma. I would like to share my thoughts on how COVID really affected us, the healthcare ecosystem. COVID-19 really challenged the healthcare system as such. All levels of healthcare delivery, stakeholders of healthcare system, such as hospitals, payers, policymakers, patients, families, they're all equally affected. You all know the effect of the COVID-19 on the patients and families. While the societies are going through shock and businesses are, retreating themselves to avoid exposure to the virus, healthcare delivery entities like us, clinic, hospitals, we don't have such option. The business must be resumed and sustained since what we do affects patients' healthcare continuum. Let's welcome Dr. Hahn, the Executive Director of Baptist Health Physician Partners, which is Arkansas's largest clinically integrated network. He's also the Medical Director of Arkansas Care Alliance, which is a joint ACO between Baptist Health and UMS Arkansas. He will share with us the pandemic response and ambulatory care strategies, and let's welcome him. Dr. Herbert Hahn for you.
Thank you, Dr. Lingasetti, and thank you, Happy USA, for the opportunity to present our experience with the ambulatory implementation for the response to the public health emergency. Baptist Health Physician Partners is a clinically integrated network, which for Arkansas is a large organization, and as Dr. Lingasetti described, also we are involved in work with UAMS, and so between the two organizations, we actually have the ability to communicate with or influence almost half of the physicians and advanced practice providers in the state of Arkansas. I'm getting some help for the presentation here from one of our junior associates. What I'll be describing is our pandemic ambulatory care strategies. And we will divide this into phases where we have the initial pandemic phase where we simply became aware of the problem and it confronted us, and then point where we were thinking about reopening our activities in the ambulatory clinics, and then the actual implementation of the reopening. We did have the benefit of the experience of colleagues in other parts of the country and of the world who were impacted by COVID-19 significantly, both chronologically before we were and by the magnitude of the impact. And so we appreciate the fact that they sustained the brunt of the initial public health emergency, but we were paying attention. Still, it came on rather abruptly for Arkansas providers as far as when the disease presented, and we needed to make a significant response. One of our roles here was the prompt communication with the providers with up-to-date information on the changing landscape. And of course, there were many things that were done as responsibly as they could be, but there were, I think as you all recognized, some rather radical changes in what recommendations were. I mean, even to the point of things as simple as, do you wear a mask or do you not wear a mask? This doesn't sound like high-end science, but that's been the nature of this disease process. There was also the transition for the safety of our staff who were not essential in the clinical setting where they had to be exposed to the risk of contracting or transmitting the disease, and to make a transition to work from home. I think anybody who was involved in this realizes that that actually represents a significant technological jump, because for historically, the vast majority of our personnel either never worked from home, and even on like what we would call a snow day, we simply shut down clinic operations, and only some of the business people in billing or coding were actually equipped to do that right off the bat. There were also certain what seemed like simple practical things, but they were profound as far as the impact on patients, such as what kind of scripting do we use for telephone instructions or website changes to be promptly implemented that would actually give the patients the ability to find out what they are to do under different circumstances, and have this be a coherent activity for the state's medical services. One of the things that has been one of our key focuses is the transitioning to telephonic or video telehealth services. The different clinics had different degrees of sophistication and implementation for these services. And then also the different payers, CMS and the commercial payers, had different timing and different implementations of what they would pay for, what the regulations or the rules were, and how it should be coded. And so our ability to aggregate this kind of information and then disseminate it on our communication platform so that physicians in the network would know where they could turn to get the most up-to-date information, and also rely that it was being contemporary with what was a changing environment. It was important to inform the members of the network and the clinicians of what the new rules were, and where they could turn to get information if they encountered difficulties or denials. There were gradual easing of a number of restrictions, as I think you're all aware, both some of the HIPAA requirements, and then also which platforms that would normally even be considered closer to social media than highly secure medical platforms But this did dramatically improve the ability to conduct telehealth services. Now, in the pre-reopening phase, after some degree of understanding and control of the transmission of the disease in the state was felt to be accomplished, there were criteria being set for reopening. Expressing my own opinion, and I think it sounds like it was the opinion of a number of the other presenters, we're not really in a controlled phase here. If you look at our graph of new cases, we're still having an ascending process here. I think that the general observation has been that not everybody is being diligent about all of the prescribed activities to try and control transmission of the disease. But nevertheless, Arkansas is still relatively blessed as far as not being overrun by it. However, we still need to be diligent and encourage the proper simple things that the population can do. The Department of Health here has been very good about data tracking and reporting, usually by county and by facility. The criteria for reopening has been responsibly published by the Arkansas Department of Health and has been supervised by the government regulators. We do have testing requirements for certain activities in the ambulatory setting. And these, once again, this is the kind of thing that we've been trying to be a purveyor of the accurate requirements so that people don't run into difficulties. We've had changes to the time course between a test done prior to an ambulatory activity, go from 48 hours to 72 hours, primarily to accommodate the awkwardness of Arkansas having rural areas that have great distances and just the logistics of getting an appropriate sample to a reliable laboratory and getting a turnaround time for the patient to be able to be tested and then also have their service provided. I think some of these practical things have been well thought out and well implemented. But once again, the criteria change rather rapidly, and we're a source of accurate information for that. The personal protective equipment requirements that need to be met by an ambulatory facility also need to be very thoughtfully and honestly assessed by that facility or organization. Travel restrictions are another thing that have real-time changes, in fact, that can change daily. Now, there are national ones as far as what hotspot internationally you can fly in from or what cruise ship you can get off of, but the local ones and even the ones that individual facilities need to impose on the providers and the staff who may want to visit family in an adjacent state or an adjacent city. We need to be diligent about where you can go and then come back from and be welcome in a clinic setting where you are the potential vector for disease. We then have conducted with this information planned reopening strategies, and also have had to consider the logistics of bringing staff back who were temporarily furloughed in order to accommodate the financial emergency that also occurred so abruptly in the ambulatory setting. Now, with the phase where we actually go into the reopening, we've wanted to encourage the continued expanded application of virtual care when possible, because this has really suddenly turned into the mainstay of great deal of the ambulatory care that can be provided responsibly and unburden the ambulatory clinics who are working at diminished capacity. One thing that's also been encouraged is to stagger the patient visits with a clinic deciding whether they want to see their healthy patients in the morning or in the evening, and the more needy or sicker ones, but partitioning the workday so that some of the activities that need to be done to accommodate those patients can be more effectively implemented. Limiting the waiting room volume by changing seat configurations that not only allows but enforces social distancing, and scheduling clinic volume to accommodate that. Limiting the number of people who are in attendance with a patient if that person needs someone to bring them to the office visit or to assist them. Clinics need to be prepared to provide PPE for patients arriving who didn't bring their own. One of the techniques that's been used, copying many of the restaurants, is to have the patients wait in a car or at home and then be notified that they are so many minutes away from the clinic being immediately accessible to them, to where they can simply be escorted in and be promptly seen. There are also significant additional burdens placed on clinic sanitation to accommodate the application of sterilizing agents in between the patient visits. Some of the things that have been done here that are perhaps not unique, but I think we are proud of. There's the activity at the Baptist Health facilities, where we are performing what we call COVID care on discharge. One of the things that's provided is a COVID care kit, where gloves, hand sanitizer, and a pulse oximeter are provided to all COVID positive patients who are discharged. I think many of us are aware that patients who have tested positive, who have been symptomatic to the point of needing admission to the hospital, who recover significantly and are discharged, there is a great body of evidence that these people, when they go home, oftentimes abruptly deteriorate without even being aware that their lung function or their symptoms are worsening rapidly, and that being able to anticipate this by pulse oximetry, to where a patient who is unaware that they're deteriorating, but their pulse ox will detect that, has been one of the things that we're utilizing. Our transition of care nurses who follow Medicare discharges from the hospital facilities had a significant decrease in their activities, simply because many of the conditions that they were assigned to follow on discharge, the admissions for those conditions in Medicare patients diminished with the advent of the public health emergency. And so they have been tasked with doing follow-up on all of our COVID positive patients on discharge, which has been very helpful. One other thing that has been advantageous here, Baptist Health and UAMS have jointly managed a graduate medical education residency program in our North Little Rock facility that is new, or relatively new, but these residents and their staff have had some additional capacity to be able to accept a significant volume of new patients. And so one of the places where we're able to get follow-up promptly for the COVID positive patients on discharge is in this facility. And that allows us especially to be able to make clinic appointments and assignments for patients who either didn't have a primary care physician in the first place, or were indigent and did not have health insurance or coverage at all. We've been able to assist our physicians and APRNs with communication regarding the documentation, coding, and billing practices to meet the requirements and regulations for payment and future identification of COVID impact. Some of these things, it's not absolutely clear what the government's posture will be on accommodating the financial impacts on health systems and providers for the provision of care under these circumstances, but being diligent about identifying when the viral epidemic dramatically impacted the financial resources of a system or a provider is going to make it easier for appropriate compensation for these activities in the looking out for the benefit of our population. We've also been able to communicate with our providers regarding the changes in virtual documentation abilities for things like annual wellness visits or HCC, hierarchical condition category capture, to help appropriately risk score the disease burden of our populations, such as the ACO. And these metrics are important both for CMS contracts and the commercial contracts. We have an opportunity at this time where patients who are not coming in, who are not getting their screenings for certain diseases, and also not capturing the chronic conditions for which they're being managed. This gives us the ability to use this time effectively and even use staff time from the clinics to help identify and manage these patients. One of the concerns that we all have is that some of the most fragile and needy people that are under our care are also apprehensive about coming to the clinic and contracting the virus. And so this was wisely expanded as an option to take care of the patients by both CMS and the commercial payers. I think that we all need to be thinking very seriously about what of all of these things that have abruptly changed as far as how we're providing our ambulatory care. What do we want to keep? What is really better than what we were doing before? And then what things are the things that you do in an emergency, like when the power goes out and all of the relatives in the area that went out come and stay with you. You know, it may be nice for a little bit, but you don't necessarily want to make it a way of life. And so I think that we can think about what aspects of these emergency responses that we've made are durable and should be optimized and even improved as we go along, and then what should be abandoned because it was simply an appropriate response. Thank you for your attention, and thank you for the invitation to address this group.
Thank you, Dr. Hahn. I think it's, you know, care continuum is something that is very important. There is a lot of small moving parts, and it really takes a massive and vibrant leadership like yours to address that properly. So with that said, the next topic is, you know, really important because not too many people, you know, share with me their knowledge and insight. But my very close friend, Dr. Prajwal Shivareddy and Manisha, when they spoke to me, you know, a couple of weeks ago, when I had questions about how COVID-19 affects the kidney, the insights that they gave was very, very kind of scary, and at the same time, very, you know, knowledge conferring, if you like. So we know that COVID-19 has multi-system involvement, and it doesn't spare one of the most organs of the body, which is, as you know, renal system. And we do have, like I said, two excellent speakers, experts here to share their wisdom on this most important topic. I would go ahead and introduce both of them. So they will be presenting back to back. Clinical updates of COVID-19 and kidney will be given by one of my most favorite physician and trainer and associate professor of UMS and nephrologist, Dr. Manisha Singh, and my very best friend Rajul Shivireddy, a nephrologist, and I regard him very high. He's so brilliant that if I get sick, I would like to go to him so he can take care of me and keep me alive. So he's a nephrologist in Little Rock, and he will share with us how he's managing dialysis units amidst of all this COVID-19 pandemic. So without further ado, Dr. Manisha Singh.
Thank you, Dr. Chandra, for that highly debatable introduction. But yes, let's go ahead and start the conversation about COVID and the kidney. Now, all of us know COVID is all about the lungs. That's right. So what are nephrologists doing out here? Our job is to support and also direct the fact what Dr. Chandra mentioned, that it is a multisystemic disorder. It's a multisystemic infection with response from all the organs. We are not an isolated organ set, it's every organ has a crosstalk. The concern has been that there are some direct reports of direct involvement of the kidney too, but of course the lungs will come in first. Even as we speak, we'll have studies coming out, and everything that we say today might be something that needs an update tomorrow. With that, disclaimer, what I want to say is that when we see kidney diseases, what do we really think of? There's an acute kidney injury that we see quite often in the hospital. Chandra, we need to go back to the previous slide. Yeah, let's stay here. I'll tell you when we can move forward. So acute kidney injury is one of the most common presentations we see in the hospital. Then there are the chronic kidney disease patients, and there can be some combination of acute kidney injury and chronic kidney injury. Acute on chronic kidney injury, acute leading to a chronic kidney injury state. And then there is the whole subgroup of end-stage renal patients who can be either on dialysis or are post-transplant. There are also many electrolyte issues that we usually address. Now, this is something as nephrologists, we deal with your everyday patients. And COVID has the right to have all of this. All our COVID patients can present with any of these combinations. Kidney-wise, specific to COVID, the two areas that we broadly focus on is, of course, to prevent infection from spreading further and manage the patient and treat the patient as needed. Our focus is on the patient and our team. Let's move forward. So between COVID and kidney, like most other things COVID, data is limited. Our best data is coming from Dr. Javeri's experience from New York when they studied the first over 5,000 patients that came and that were infected with COVID. Of the first 5,500 patients that were admitted, about 37% of that cohort developed acute kidney injury. Of those patients that developed acute kidney injury, about 14% required dialysis. Among more than 1,000 patients that were on a ventilator, about 90% developed acute kidney failure. And of the 925 patients who had COVID-19 but did not need the mechanical ventilation, only about 21% developed acute kidney injury. What that tells us is, like any other case scenario, the sicker patients end up getting acute kidney failure. And in this case, there was a very high number of patients that would head for acute kidney failure. Hematuria and proteinuria were noted in about 46 and 42% of patients with AKI. And this was a very interesting phenomena because hematuria and proteinuria also presented as isolated events in some cases. And in my experience too, a few of our patients had come in with, had these transient hematuria episodes that came and went suddenly. And we were not able to ascertain the significance of this. Now, what actually happens in the kidney, the best result we get is if you get a biopsy. Now, it's a very difficult thing to get a biopsy in a COVID positive patient. It's difficult to get a biopsy anyway. Out of the case reports that we have so far, out of the studies, and one of them has come from Dr. Larson's group, which is Arkansas based, where they found collapsing glomerulopathy as the way that the kidney was affected. And this was specifically in African American patients, and they had ApoL1 risk factors. For all the nephrologists out there, we know that collapsing features are something that we can expect with that kind of a genetic risk. Chinese studies showed multiple different ways of tubular injury, and that is the experience of most hospitals. For acute kidney injury, the acute tubular necrosis, the ATN, being 80% of the cases that we see, and AIN being acute interstitial nephritis are the presenting things as far as the histopathological slides are concerned. There are also case reports coming out in which they have seen RBC CAS deposition, and we don't know how it's seen usually in very, very severe cases. And as I speak, there are again multiple studies coming out. There are some people who've done a lot of autopsy studies, and they're seeing different kinds of histopathological features. More data that I wanted to present is, of course, what you know, the higher risk for acute kidney injury happens in the same group that we expect acute kidney injury and chronic kidney injury, older age group, Black patients, history of diabetes, hypertension, cardiovascular disease, being on the ventilator, and use of vasopressors. Now, being on the ventilator and use of vasopressors implies that the patient is quite sick. Having a Black race, I do want to point out here specifically for the disparities. Now, chronic kidney disease is one of those diseases where disparities are extremely evident. And there are multiple reasons. It's not just genetic why African American patients end up having a worst case scenario in our healthcare system. Now, coming back to COVID, more chronic kidney disease patients had severe acute kidney injury presentation. And that's again not surprising because they have such poor residual renal function. In addition, hypertensive patients had severe acute kidney injury. Now, this is also something to be taken with a grain of salt because pretty much most of your older patients would be hypertensive. For chronic kidney disease patients, our top two reasons are having hypertension and diabetes. So any and all combinations of these risk factors were present in our patients too. Now, so how badly does it affect? How bad is it for a COVID patient to get an acute kidney injury? In critically ill COVID-19 patients, kidney involvement is actually quite frequent and it can be persistent, especially if the acute kidney injury duration goes over 3 days and the patient ends up needing dialysis. 20% of these patients will have some degree of persistence of kidney injury. And this study underscores the need for follow-up nephrology care. Now, a lot of us, we are still grappling with the advent of the patient to the hospital. Now, this is discussion about what to do after discharge. My recommendation is going to be that patients that had acute kidney injury when they were admitted should have a nephrology follow-up after their discharge. Now, commonly asked renal questions. Now, there's a lot of fascinating aspect of COVID and renal disease, but I wanted to specifically address a question we've been asked quite often by our primary care providers, and that is, and our patients, that should we stop the ACE inhibitors? That sounds like a very strange question, but it really isn't very strange. It's actually a very valid question. It's valid because we know that SARS-CoV, one of the targets that we do know is that ACE2 is one of the receptors for SARS-CoV COVID virus entry point. We also can opine that RAS inhibitors could increase the level of ACE2 receptors. Now, why this is kind of something that we see quite often, any medication that we use that works at the receptor level tends to increase the number of those receptors. It's just body's way of handling something. What does ACE2 do? Now, those of you that like ACE inhibitors would know that there are two types of ACE receptors. The ACE2 is actually the good guy. it's the one that eventually ends up downstream stopping the effect of the Ang2 wave that happens after activation of ACE receptors. So we really didn't, so initial concerns were that ACE inhibitors should be stopped. But current data, and even like I said, data is coming in as we speak. And right now, just before this talk, I saw Kidney 360 has just published that they also recommend the same thing. That is that we do not, for all professional societies that have opined on this, they have not opined that ACE inhibitors should be stopped. Severe COVID-19 rates were same amongst people that were on an ACE inhibitor compared to those that were on some other antihypertensive drug. Now remember that hypertension in itself is a risk factor for worse COVID disease. From China, we got the study saying that one of the large retrospective cohort studies showed that they actually had lower mortality at 28 days. Going forward, what should we do? So right now, what we are suggesting is that we do not change medications unless indicated due to clinical needs. Now, if you have a septic patient who's getting hypotensive, you would have stopped all antihypertensive agents no matter what. So this would be quite appropriate time to stop the ACE inhibitors if the patient is on it. But if there isn't a clinical indication, we really wouldn't go that route. In fact, stopping the ACE inhibitors in a patient that needed it will exacerbate their underlying cardiovascular or kidney disease, which will certainly result in increased mortality. That is like in any other patient who needed an ACE. If you go ahead and ACE inhibitor, and if you go ahead and stop that, that person's mortality risk does go up. So we can expect that to happen. There are some other treatment areas to focus on. Other than that question, we are often asked about optimization of volume. In acute kidney injury in a COVID patient, this is of critical importance. We have to have a very fine balance between avoiding hypovolemia, which can lead to prerenal acute kidney injury, and avoiding hypervolemia, which will result in that severely poor respiratory response. ARDS any day gets worse if the patient gets hypervolemic. So what we suggest is, of course, continue the medications the patient was on unless there's a clinical indication to change the medication, and target, so that is with respect to diuretic use, we still hold that. And in fact, you can go up on the diuretic use if the patient is still responding to diuretics, and start renal replacement early if you're thinking of it, has been our principle. So what about transplant patients? The other group that asks us this question is that should we just stop our anti-rejection medications because they are immunosuppressed? So what are we going to tell them? And the other question is, should we continue with doing renal transplants? You know that UAMS is a tertiary center and the only center in the state that does renal transplants. There was a machine simulation study that showed that weighing the potential risk of COVID-19 infection in the patients that come in for a transplant, kidney transplant still provides survival benefit to the transplant candidates. So we, like many other centers in the country, did not stop the transplants, and our transplants are still ongoing. Now, if the patient is infected and is sick, like we would for any other patient in that clinical state, we would decrease immunosuppression. But if they're not sick, we would likely not change their immunosuppression if they are, just at risk, or if they, so you won't go and stop immunosuppression in a patient that does not have any infections. I had a little bit of a scare from one of our transplant patients who really wanted to stop their medications, hoping that will be one way for that patient to prevent infection. That's not how it works. The New York experience has been that kidney transplant recipients, and this is important for us to know, the kidney transplant recipients with COVID-19 had less fever as an initial symptom. So they might not get through those screening questions. They might not, raise a red flag with those screening questions, but they had a rapid clinical progression than the general population. they are immunocompromised and they can get very sick very soon. So having a low threshold for getting those patients in your radar is important. Now, some other renal topics that were there in literature that I would like to bring to your attention. One was that there was a study showing a statistical correlation between degree of vitamin D deficiency and severity of the COVID-19 lung disease. Does that mean that giving high dose of vitamin D would prevent the disease? Not really. We don't know that. We don't have enough data to say that, but we do have some data having a slight amount of linkage. In China, they also studied selenium, which seemed to provide some benefit to the cure rate. They found that they measured the amount of selenium in hair, and they felt that the people who had no deficiency of selenium did better as far as cure of COVID was concerned. But right now, none of the professional societies are recommending selenium, so I do not want you to go and buy all the selenium off the racks at whichever pharmacy you have access to. Just like zinc, we do not know if it will change the course of the disease, but we do know that it has been used for other viral illnesses, and I won't fault a patient for trying it. I would just warn against overdoing anything. Now, a lot of very good data is available on those. There are some resources that I have put out here that you can go and read these topics in much more detail. I was asked a question regarding CRRT use, and in the acutely hospitalized patients, those that were in the ICU, we did elect to put them on CRRT. We had a very specific plan for these patients because our focus was in treating these patients and protecting our staff. We took away the need for documentation as much as is required by the nursing. We elected for very timed lab draws, and I would be happy to go over how we did the CRRT for those of you that are interested in inpatient CRRT and inpatient hemodialysis plans that we made. I would hand over to Dr. Prajwal Shevireddy, an excellent nephrologist.
Thank you, Manisha. It was an excellent presentation. And thank you, Chandra, for a very humbling introduction. So I would like to kind of briefly talk about all the changes that we had to do in the dialysis centers because of this COVID-19 pandemic. I'll try to talk a little bit about the inpatient dialysis and then the outpatient dialysis as well. So when it comes to the outpatient, I'm going to talk about home dialysis and in-center dialysis too. So as far as I could tell, I couldn't find any national database anywhere in the state or the country where I could find how many ESRD patients have been affected by COVID-19. And if you guys have any data regarding that, please share it with me. So the challenge with dialysis patients is that the dialysis itself, presents with unique challenges, especially the patients. One, they're very vulnerable population because they're elderly, they have a lot of comorbid factors, and a lot of them are severely immunosuppressed. And to add to that problem, they also come from very high-risk environments, such as nursing homes, rehab facilities, and very often they share their ride with other patients who may be exposed to COVID. And once they get to the dialysis unit, the nursing staff tend to work very closely with the patients in very close proximity, and it requires multiple interactions. So as you can see, this is going to pose a lot of problems. So let me first briefly talk about what we did in the inpatient in the hospital setting. So now at Baptist Hospital, at least where I'm working most of the time, all the patients are being tested for COVID, which is definitely a good thing. And while we are waiting on the testing, if somebody is low risk, it takes about 48 to 72 hours to get the results. And in these low risk patients, when they need dialysis, they're getting dialysis in the same dialysis unit, but with all the protection, the nurse staff wearing all the PPE. And we are trying to do dialysis in a dedicated part of the room so there is less cross-contamination. In patients that are high risk and COVID positive, we converted actually 2 patient rooms into isolation rooms, and that's where they're getting their dialysis treatments. So there's no interaction between the regular unit and these rooms. And the bigger challenge is in patients that are in ICU. So for regular dialysis, once the dialysis is initiated, the dialysis nurse is coming out of the room. And at least in this hospital, we are fortunate because we have like really big glass doors. We can close the room and the nurse can stay out and continue to monitor how the treatment is going. The bigger challenge is in patients that are on CRRT. So to minimize the risk in these patients, we've kind of minimized the number of changes that we do, the intake and output balances. And when we try to change the fluid, when we have to change the bags, we are trying to do 2 or 3 at the same time, so the nurses are not going in and out all the time. And that seems to kind of help a little bit. And then in outpatient setting, for home dialysis, when the patients come for their monthly labs, so we take, of course, all the precautions. They get their temperature checked as soon as they come in, and they're mandated that they need to wash their hands, disinfect with a sanitizer, and they have to wear a mask. And the nursing staff is wearing a full PPE to protect themselves and to protect the patients. And when we deliver the supplies to their home, we've been delivering it to the front door, not inside the house, so to minimize the contact between the personnel and the patients. And then for the outpatient dialysis, so we've taken several precautions. And I mean, there's usually a significant waiting before the patient can actually get into the dialysis unit. So what we did in the waiting room is that we made some changes. So no family is allowed to come inside the waiting room unless absolutely needed, somebody that really needs assistance. And then, of course, we are trying to maintain 6 feet distance. We've taken half the chairs out of the waiting room. And if it is getting crowded, we ask the patients to wait in the car so that they're not coming inside. And then everybody gets checked for a fever. They're asked if they have any symptoms, any exposure history before they even come into the waiting room. And everybody is mandated to wear a face mask, no exceptions at all. And all the staff members, and even when we visit, we have to go through all of those same things. So we have to wear a full PPE when we talk to the patient. I mean, when we get close to the patients, we get asked for all the symptoms, we get our temperatures checked. And then once they're in the dialysis unit, the patients have to wear a face mask all the time. And most of our patients have been very unhappy because we said no food or no drinks in the dialysis unit. Because every time they need to eat or drink, they have to pull the mask down, and that poses a big risk. So we said absolutely no food or drink, and that's kind of been the biggest complaint for most of the patients. So we had to educate the staff and the patients repeatedly, almost like on a weekly basis, so they understand why we are having to take these precautions. And then in between the treatments, we are wiping off all the surfaces as much as we can. And our visits, when we visit the patients, we've been doing mostly televisits rather than going in person. And then we've completely stopped taking out of the state visitors unless they have a negative COVID test in the last 48 hours. And even the patients that have been in the hospital, especially if they've been intubated, they need to have a negative COVID test before they come back to the dialysis unit. And then for the patients that have been tested positive or have been exposed, we've been fortunate enough because we have several dialysis units that only run shifts on Monday, Wednesday, Friday. So we were actually able to open up TTS shifts so that these patients can go there and then do the dialysis treatments away from the rest of the patients. In the dialysis units where we could not do that, we've created some isolation rooms where the patients can directly go to the room, kind of bypassing the waiting room to minimize the contact, and they've all been shifted to the kind of the end of the shift, late day, the last shift, so to create any kind of cross-contamination. And most of our patients surprisingly have been very cooperative with us, and they've kind of done very well. And I would like to end this topic on a kind of a very happy note. And as of today, we do not have any of our dialysis patients that tested positive. And I would like to thank API and everyone that is present today for giving me this opportunity to talk today.
Prajwal, thank you. As you all know, Manisha, Secretary of API Arkansas, Prajwal, past treasurer, very much in the governing body of our API Arkansas chapter. So everybody else who are all on the speaking panel today, including moderators, and the question gatherers and helpers, what you call, they're all leaders of API Arkansas. Really honored to be with you. So our next speaker, surprise for you. And Manisha, you know, since you asked for women empowerment in API Arkansas, here you go. So we got Arpana Idala for you. She is passionate, you know, physician, and she takes care of elderly very close to her heart. She's a geriatrician. She has been primary care provider and also medical director of several long-term care facilities. Her passion towards patients who are vulnerable and elderly, it just impresses me, and I haven't seen anyone like her. I really thank her for joining us this evening and share her thoughts on you know, COVID and long-term care facilities. Arpana, the stage is yours.
Thank you, Chandra, for such a humble introduction. And thank you, Api, for giving me the opportunity to talk to the team. So I know that long-term care facilities have been in the limelight for COVID-19 outbreak and pandemic. It has been a challenge as a medical director and a provider to care for these patients, especially with you know, isolation and PPE in the beginning. It was a chaos, but we have learned our way slowly and steadily to do better every day. And so we are bracing up for the, you know, worst to come, which we are all expecting. So the few points that I want to highlight today are isolation and testing in the long-term care, and PPE status, which is much improved now. So as far as the isolation goes, you know, we initially used to isolate the patients who were positive only. But because of the increase in the cases in Arkansas, we have implemented isolation for everybody who comes into the facility upon admission for 14 days, irrespective of the test result, which I think is going to help us a great deal. And then, of course, for the COVID positive patients, we are doing the isolation, but unfortunately, the downside in the nursing home is that we do not have the airborne isolation, which is a big limitation and you know, causes the spread of the disease. As far as the testing is concerned, as Dr. Naveen Patil mentioned, the facilities were tested, you know, widely, both for residents as well as staff. Recently, 100% of the staff were also tested, and fortunately, they have all been negative, as he mentioned in the talk earlier. And of course, we are testing the patients who are positive for typical symptoms like fever, cough, and shortness of breath. But in dementia patients, as you all know, and also with patients who have other comorbid conditions, we are testing the patients who have atypical symptoms also, like change in mental status, which is a big one, confusion, COPD and CHF exacerbations, and diarrhea and vomiting, which are, you know, a very atypical GI symptoms. So as far as the recurring patients are concerned, we do test them for 2 negative before they come into the general pool of the patients. So it has been a challenge for that, because the testing in one of the nursing homes, it has repeatedly been positive, and we are praying that in the next week or so they are all going to be too negative. So we are hopeful about that. As far as the PPE is concerned, we implemented mask way early in the nursing homes per CDC guidelines and Department of Health recommendation. And we are fortunate for the Arkansas Department of Health, who has provided enough PPE now in the nursing homes, and we are prepared for the worst to come. And the next one that I want to really request, as far as the hospital transfers are concerned, to test every patient that would be transferred from hospital to the nursing home, and so that it is easier for us to categorize and care for those patients in the nursing homes. It was a big challenge in the past couple months, but now with more testing availability, most of the patients are being tested before discharge from the hospital, which we consider it as one negative, and then the second one would be done at the nursing home while they are in isolation for 14 days. So that has been very helpful as well. So the patients who are readmitted to the nursing homes, and the patients who need skilled nursing facility care, it has increased in number, and we are getting more and more testing. And isolation of these patients has been a challenge, but we are handling it pretty well in the nursing home section. It is really a different ball game, because we as providers see the acute care setting and the ambulatory care, but the nursing home is a total different matter, especially with the staff members, 3 shifts, multiple therapy people with skilled occupational and speech therapy, and the CNAs and the LPNs, and the number of exposure to these residents. It is just very difficult to handle. That's all I can say. And the next one is, as we reopen the state, July 1, the families can visit the loved ones in the nursing homes. And we are dreading about that as well, as you can imagine. So we have implemented a few policies in the nursing homes. The first one would be, asking the families to make the appointments so that it is not crowded, and everyone will be screened for the symptoms and checked for temperature when they come to the nursing home vicinity. And then we have implemented that they would not enter the nursing home, which would also be helpful for us to contain the disease. And the families have to wear the mask, of course, and the one family member at a time with 6 feet apart. And then we would have the visitation in front of the nursing home, so that they would not enter the nursing home and bring the virus. So these were all my challenges in the nursing home. And I have had one facility which was hit pretty hard with almost 90% of the patients being positive, but they did really well, and we have turned around, and most of the nursing homes, as Dr. Naveen Patil said, have handled it very well with their guidance. Thank you. Thank you all.
Arpana, thank you so much for that insightful talk. And I think that's really important since, there are a lot of challenges when I'm, with my experience as a hospitalist, there are a lot of challenges in terms of, where we send these patients and so on and so forth. Well, I think we almost came to an end of this session, but really important agenda item right now is answering questions. So I would like to request our API Arkansas regional leaders Dr. Sudhir Koigura. He's in charge of Northwest Arkansas. And Devi G. Nair. She is from Northeast Jonesboro. And Shailendra Singh is from Batesville. Three extraordinary regional leaders, and they have started regional groups, regional chapters on their own from scratch. The amount of member engagement, the amount of charity and education work, and you name it, all the activities, core activities of API Arkansas have been adopted by these three extraordinary leaders and grown so much. I really thank them for coming up. So Sudhir Koigura, so you're on. So go ahead and shoot the questions to testing and plasma speakers. Go ahead, sir.
I think this question is for Dr. Tina. I think the question is there any other passive immunity therapies are being developed for COVID-19? Are they in the process? Any passive immunity? Is there any immunity therapies?
Well, I mean, convalescent plasma is a passive immunity, but also there are individuals that are working on developing hyperimmune, otherwise known as IVIG. That is going to take a little bit longer because IVIG or hyperimmune is actually created by collecting about 10,000 or so donors and then taking their plasma through a process called plasma fractionation and specifically targeting the antibodies for COVID. Given that we really do not know, we do not know if these antibodies are neutralizing. It is still in very early development. At this point in time, a lot of hyperimmune or IVIG companies are in the process of collecting plasma donors and testing for antibody titers, and then shortly thereafter we'll determine whether it's neutralizing or not, and then we'll develop it. It's going to be about 6 months at the earliest that therapy would potentially be available. But at the present moment, to answer your question, the main passive immunity is really through convalescent plasma, as we do not have as we do not have vaccines available for this disease.
Thank you, Dr. Yeah. I think this question is for Dr. Atul. I think I would like to ask you, like at our facility, we are testing everybody who comes to the hospital. Like the patient who comes to the hospital, we are testing and needs to be admitted or not, that's a different story. But today we had a point, our administration made a point that like, how long we are going to do that? We are going to have enough tests. What do you recommend?
So like I said right at the start when I made my presentation, the only way to find out about a pandemic, if you're preparing for it, is to have enough tests. And if we're at all concerned about what's going to happen in the fall, we have to think about testing capacity when every patient with fever may have flu or may have COVID or may have both. Testing helps us to target where disease is spreading. So nationally, while we see that the disease is increasing in the US, the number of cases are increasing, that is not distributed evenly. And you actually have really good county level data where you can see that in which county is the disease increasing, and that helps us to target control efforts in that community. So the way I think is more testing is going to be really, really important. It predicts how the disease is going to spread in the community.
Thank you, Dr. Patel.
Thank you. Devi, any questions to reopen clinics, speaker, anything?
Yes, so there was a question, I think Dr. Kothari actually answered it on the chat, but I wanted to just get it out to the all the participants. There was a question regarding clearance to return to work, especially for healthcare workers, if they were exposed to COVID or if they were affected with COVID, what type of testing would you recommend? How much isolation and what precautions?
So because this is a national talk, so different health, I'll take the question because I answered it and I'll answer the same way. I will not speak about other jurisdictions, but here in Arkansas, what we've decided to do is go with a symptom-based isolation policy. So if you do not, once 10 days from onset of symptoms is when you can be cleared from isolation, as long as you do not have fever for the past 3 days. Healthcare workers becomes a lot more complicated because healthcare is considered critical infrastructure, and employers may ask healthcare workers, especially right now when hospitals are surging even without COVID, they may ask healthcare workers who are asymptomatic to come back to work. You'd still be expected to quarantine when you go back home, but you're supposed to be in face mask all the time. You're supposed to have your temperature checked. And if you're symptomatic, you're supposed to be sent back home. So that part we don't really get into. We leave it up to the employers to decide, have some leeway in deciding that.
Well, thanks, Dr. Kothari. I'm going to address this question to Dr. Hahn. So there was a question about what kind of legal implications or obligations may arise as we open our practices. Are you concerned, or how do we address things like nosocomial COVID?
I think that the state is implementing insulation to healthcare providers for contraction of COVID, under any of those circumstances, as long as there wasn't some sort of malicious or negligent activity, so that and I think that there's, I don't know how specific the legal terminology is, but I think there's an intuitive sense that there won't be liability for people transmitting that disease in the healthcare setting. Now, I think that the greater concern really is in our community here for simply the responsibility of trying to minimize that transmission of the disease, just as a responsibility, to each other, and the sort of the litigious legal ramifications, I think, are being dealt with appropriately at an administrative level.
Thank you, Dr. Hahn. I have one more question, and it was about, and I'll open it up to any one of the speakers about what kind of safety measures. And I think, Dr. Hahn, you kind of spoke of some of those, but some of the safety measures that you could implement for the patients. How much of a tele-triage program can you have in place as we reopen? And do you see telemedicine staying?
Well, certainly. I mean, I'm a big advocate of the refinement of our telemedicine implementations, and I think one of the things that we've observed is both patients and providers are becoming much more familiar and much more agile with these modalities. And I'm not sure that we're not seeing some of it, like we would worry that elderly patients would not be agile with trying to handle a telemedicine consultation on their phone. But because so many of them have been isolated from their own grandchildren, and the grandchildren are certainly agile, I think they're doing FaceTime and things so that the teachers are out there. And no, we wouldn't have gotten anywhere with this just as we were going along before, but COVID has really compelled many people to embrace this technology, I think, rather enthusiastically. And I know my observation has been, well, just like conducting this conference right now, the chances that this could have occurred as smoothly as it has a year ago is zero, whereas now, not to brag on Dr. Linkasitti's technology expertise, but this is very, very, very slick. And I mean, I can tell that all of you have also gone to some trouble to be able to create video and audio that's really very, very manageable. And so I think that the world is going to be following this, not just with how we've done it right now, but I think 6 months from now, we're going to be vastly better at some of the same permissions are going to let us be vastly better. So I think that screening people, I mean, I don't know how soon everybody's tablet is going to have a thermometer on it, but.
Yeah, I think that, yeah, I really agree with that. We've done a survey among providers. I'll just tell you two numbers. One, the use of telehealth among providers less than 1% before COVID hit us, at least in Arkansas. The use of telehealth right now, obviously, is more, but the other number that I really wanted us to be mindful of is 20% of providers are thinking that there is going to be a permanent telehealth in their life. So 20% of the healthcare will be delivered. So virtual will be new real. That's the word I would like to say to answer that question, part of that. Thank you.
Thank you.
All right, next up, Shailendra Singh from Batesville. Shailendra.
Hello. Hi,
Hey.
can you hear me?
Yeah, it's your turn. So I know that we're gonna, close this conference today with a little song from you because I know you can sing well and dance well. But before
Oh my God, I can dance, but I can sing for sure, I can assure you.
okay, we can test that. So,
Thank you, thank you.
You're welcome.
Well,
Yours.
thank you for giving me this opportunity. Now, let me tell you, Dr. Singh, Manisha Singh has been on top of it. She's been answering the questions on the sidelines, but for everyone else's knowledge, this is a question asked in the chat, and she has already answered, so I'll let her answer it here for everyone else to listen. So, Manisha, CKD patients are at high risk of MI and stroke. And so question was, should these people be protected with statins, especially in these COVID times? And if yes, then who should be responsible for making sure that they get their statins, PCP or the nephrologist? Because a lot of time care gets compartmentalized, PCP taking care of certain thing, and they think that nephrologist is now taking care of kidney, and they would take care of everything for them.
That was an excellent question that came through. And regardless the times, for chronic kidney disease patients, the guidelines since 2013 have been that we have every patient who's above 50 years of age to be on a statin if he or she has chronic kidney disease. Below 50, also the recommendations are there for patients that are at higher risk of cardiovascular events. Pretty much all our chronic kidney disease patients will be dying of a cardiovascular event. That's why it's so important to use whatever we have to prevent any further insults to the cardiovascular system. For our practice, so I want to back up and say there are two things. One is a grant that we have from NKF, which is specifically addressing awareness of chronic kidney disease in primary care providers. And one of the points that we talk about is use of statin or drugs that are appropriate for that patient. Regarding my own practice, I believe that if there's a right thing that needs to be done, I should be the one doing it first. And what I do is I start the patients on the statin when indicated, and I alert the primary care provider that I have done so, because the primary care provider might be seeing the patient and more often than I would, and may have some other concerns and may be able to address side effects earlier than I might. Going forward in severe chronic kidney disease, actually I end up seeing the patient much more than the primary care provider would. I would be probably following the patient monthly, whereas they would have 6 monthly follow-ups with their primaries. In that case, we emphasize age-appropriate cancer screening, vaccinations, and it's a good idea to work closely with the primary care provider.
Great, I say it's everyone's job. Whoever get the opportunity, because in the end, patients should benefit. Okay, so next question is also for you. and the question is, does the collapsing glomerulopathy reversible? Does it resolve when the patient recovers from COVID?
Unfortunately, whenever we have a glomerular injury, that is usually not something that we are able to see as reversible as a factor, mostly because we are unable to follow these patients. The initial cohort that was studied, few of those patients went on hemodialysis, though clinically they did much better life-wise, quality of life-wise, but there wasn't much of a renal recovery. But the part that is acute, the tubular injuries do tend to do a little better. I am not sure if we have long-term data right now to see if the GNs are going to improve. I doubt that part.
Great, thank you. So I'll let the next question go to Dr. Chavi Reddy. Or how do you take care of PD dialysate? Does it need a special treatment for people with COVID?
Not really. So what we've suggested our patients to do is when we dispose of the PD fluid, it's just going to go into the toilet like we normally do. But we tell them to make sure that it doesn't splash, because if it splashes, then it's contaminating the surrounding areas. So they need to be a little bit cautious with that when they're dumping it in the toilet. And then as far as the lines are concerned, we're using a single-use lines. And then we usually ask them to double bag it and then store it in a separate place. And then after 3 days, then dispose it off in the regular trash to kind of avoid the contamination.
Great, thank you. Now, one question, I do not know who should this be targeted to. I think anyone can answer. And this question is, what do we expect in long-term complications of COVID? What we are seeing is short-term acute manifestation of COVID virus. Do we expect any long-term complications of these patients who suffer? Because when I'm looking at carefully, I'm looking at another virus which have similar kind of presentation when people get sick with it. It's called Epstein-Barr virus. And we see a lot of long-term complications for that. What does anyone has any thoughts that what long-term complications we can see in people with COVID-19?
Yes, my concern is fibrosis, because in the lung injuries that we saw extensive fibrosis. I do think these patients would be left with severe fibrotic disease of the pulmonary stature. And similar to that, in the kidney also, I'm quite sure we are going to see a lot of residual chronic kidney patients.
Great. Any autoimmune, long-term autoimmune diseases we can see in these people?
Maybe you can answer that.
Well, that's a question which we have to look and we have to answer. Definitely that comes to my mind. We do see, because if you look at the way virus replicate, they go and incorporate it in our DNA, and wherever they get incorporated in the DNA of the cell, they can activate certain cells. And some of the viruses, especially Epstein-Barr virus, cytomegalovirus, and what we are seeing with COVID is, it probably gets incorporated in some of those places where it triggers the activation of the immune system. There are two possible reactions for this. One, it being a novel virus, where our body does not recognize it till it has replicated overwhelmingly, then body suddenly recognize it has been attacked by a big army and activates the immune system. And the other possibility is it getting incorporated in the section of the DNA where it can activate the long-term activation of the immune system, leading to increased autoimmune diseases. That is a very interesting thing which we will have to follow. What do we see in future?
Thank you. Any questions to Arpana on long-term care? Naveen Patil addressed it pretty good, and Arpana, thank you for your work and all your passion. Again, I think any other questions, if they came in the chat box in the last few minutes, we can probably answer. But it looks like a lot of thanking messages and stuff. I'll take all of them to me. All those thanking responses to me and all the questions to you guys. All right. Again, I would like to thank you, API Arkansas and API USA for this opportunity. Dr. Suresh Reddy, National API USA leader. He's a very vibrant and dynamic leader. I admire him a lot. And Seema Arora, the chair of the BOT, and Vijaya Kodali for all of her help with the presentation, help with the making a flyer, and really kind of walking with us with her, with hands and in our chapters, baby steps, and also our president, our own president, API Arkansas president, Naveen Kumar Jain. He's a gentle giant, and the things that he do are giant, but he's very gentle. Thank you for that, Naveen, for everything that you do, and all our esteemed API Arkansas leadership, governing body, office bearers. A lot of work goes into what we do every day, and all API members who are the reason why we're here. And of course, the guests today, Dr. Han and other guest speakers and guests, and all of you. Thank you. Stay safe, and it's a pleasure. Good night.
Thank you, Dr. Chandra Lingishetty. Thank you for the opportunity.
Bye.
Thank you for the
Thank
opportunity.
you. Thank you all.
Thank you, Chandra, for organizing this. It was excellent.
Thanks, Chandra.